So, good evening, everyone. I welcome you all for this fourth module of the EBUS certification course organized by Indian Association for Bronchology. This certification course has 10 modules for EBUS, which will be in a webinar form, and then 4 workshops, one in each zone of the country. To obtain the certification from IAB, you need to attend at least 8 of these webinars for at least 90% of the time. And you need to have at least one physical workshop attendance in any of the zones of the country to get this EBUS online certification course certificate. With that out of the way, let me welcome you on this day of Navratri. You can hear background noise in my audio of the Dandiyaras happening here. We have a great faculty for this module 4, and the captain of the ship today is none other than Dr. Nitin Abhyankar. Dr. Nitin Abhyankar needs no introduction. He is the Vice President of Indian Association for Bronchology. He is one of the first guys to get European diploma in respiratory medicine. He is the HOD of Pune Hospital, and he does a lot of interventions. So we can be very rest assured that he is a very good captain who can take the ship forward with a big star cast today. Before I hand it over to him, I need to thank our academic partners, Mankind and Olympus. In Mankind, specifically, Mr. Nitin. So, Nitin Abhyankar, sir, over to you.
Thanks, Mehul. And this is going to be different from the first 3 modules that we had. We are now trying to go beyond the basic EBUS and trying to improvise our techniques in linear EBUS. We are not yet into the radial EBUS, but improvise our yield into the best possible zone. And I'm sure Dr. Vikas Marva, can I have his slide, please? His introduction slide, yes. Let me introduce our speaker for the day, Dr. Vikas Marva, who is a consultant pulmonologist in respiratory medicine. He's right now in Rajouri. I have had the privilege of working with in Pune, and is a fantastic physician and a great orator. He has won in 2006 the Best Paper Award and a number of military awards, which includes the Sena Medal, the President's Gold Medal, the Chief of Army Staff Commendation, Vice Chief Commendation, and all that. And he had one of the best presentation in ITS Yorkshire in 2017. He's been devotedly working in number of clinical trials, which includes WHO's Solidarity trial, the Solidarity Plus trial, ICMR National COVID Vaccine trial, so on and so forth, and Indian National Pulmonary Tuberculosis. So we have a person who is academically extremely focused and interventionally extremely well oriented. He has nearly 15 book chapters and 135 plus journal articles. 21 of them are international. So I think you have somebody whom we can look forward to, and look at the stars which are there on his photograph. I'm sure you will be more than convinced that he is one of the most accomplished, both on the military side at the same time on the academic side, as one of the best persons to talk about improving or improvising the yield in EBUS TBNA, the convex pulmonary one. With that, over to you, Dr. Vikas, and welcome to you on this platform, and the platform is yours.
Can I share my screen, please?
Yes, please.
Is my screen visible?
Yes.
Very good evening to all of you. At the outset, I'd like to thank Dr. Nitin Abhyankar for the kind introduction, and IAB for giving me the opportunity of speaking on a topic actually to improve the yield in EBUS, because I have been through it after my fellowship. When I came back to India and we set up a facility in AFMC, I have gone through the motion. The technique was the same, but the yield wasn't coming. So, I'll go through it the way we did it. So this would be the outline of my talk. I will be talking about the determinants of diagnostic yield in EBUS with some technical aspects, and whatever I speak will be evidence-based, and a little bit of sample processing, which is very important to improve the yield, and a bit about the newer methods, and then I would summarize. So what is exactly the difference between a yield and a sample adequacy? So I go back to the conventional TBNA when this definition was given in 1999 by Dr. Mehta, and there it said that if you have adequate lymphocytes, a preponderance of lymphocytes should be there with absent or rare bronchial epithelial cells on the smear with strict criteria for cytologic diagnosis of malignancy. So this is the basis of a adequate sample, which may or may not give you a particular etiological diagnosis. As for example, we get chronic non-specific inflammation. So if you have lymphocytes, there is a diagnosis, but the sample is adequate, but you don't have an etiological diagnosis. So this is a difference between a diagnostic yield and a sample adequacy. So with EBUS, we can provide a sample adequacy, but it should be, the right test should be sent, like a gene expert in case you want to have a chronic non-specific inflammation with a gene expert positivity, then probably you will be able to diagnose tuberculosis. Now, the yield differs for different diseases. As you all know that EBUS started for malignancy in the West, and the yield is maximum for it. This is a meta-analysis which shows that 88% pooled sensitivity for malignancy, and it is much less for benign diagnosis. In our country, the clientele which we see with mediastinal lymph nodes, most of them have got tuberculosis rather than malignancy, and there's a lot of necrosis in the center. So the yield is much less in benign diagnosis. And the least yield we get is in lymphoma, which essentially needs, rather than cytology, it needs histology and histopathology for diagnosis and a lot of molecular markers. So we usually struggle with diagnosis when it comes to lymphoma. So going back again to conventional TBNA, because if you have to understand EBUS TBNA, you have to know your basics for the conventional TBNA. So the 6 T's which have been described, which is the CT, tomographic evaluation, type of needle, technique, tissue preparation, which is still so relevant today, the interpretation by a good cytopathologist, which is a rarity, and trained assistant. So these are the 6 T's. So if you look at the timing, either the factors which improve, on which the yield depends are pre-procedural, which depends upon the training and experience, obviously, because it is quite operator dependent. The choice of lymph node, which you actually see on the CT, the station, the size, which is very important, because if you start doing your EBUS with a subcentimetric lymph node, the yield is not going to be great. So when you are beginning, you should start with a larger node, probably 15 mm, something which is close like subcranial node, to get a better yield. Then there are various procedural factors such as the size of needle, type, use of stellate, and the new slow pull technique, which I'll be discussing, use of suction, number of passes, and the agitations inside. Post-processing is as important, how to process the sample, and the training of the cytopathologist is also very critical in getting a diagnosis. In fact, that I would say is very important, and you should always keep them in good humor. Offer them a cup of coffee or pastries whenever they come to you. Then only you'll get the right diagnosis if you have that kind of involvement. This was the article which we published some time back regarding the yield. So we started our facility at AFMC, and initially I was a bit frustrated because with the same technique, I was not getting the kind of yield which I was getting when I was doing my fellowship at Leeds. So I looked at the slight processing factors, the training of the cytopathologists. I would like to say that we have very good histopathologists in our country, but very few trained cytopathologists. So that is where the yield suffers. So once you correct that factor, the yield automatically goes up. So in this paper where we had 116 patients with an 85% yield, for the first 50, the yield was just 60%, because majority of our work is not cancer, it is tuberculosis. So that is why, as you see, that 66% of the patients here had tuberculosis. So into TB, the yield is not as high as for cancer. So first things first, you have to look at the CT films. Before you start, you have to look at the nodes you want to hit. You have to choose the node. Look for the large node which is easily accessible. So when you're starting, look for a large subcarinal node, because that is the one which is easiest, and the right paratracheal node, which are easiest to hit with the EBUS when you are up the learning curve, because this procedure definitely has got a very steep learning curve. There's so many, as it was told in the last webinar, there's so many steps to go through with the EBUS needle compared to the conventional TBNA needle. So best way is see one, do one, and teach one, because in a training environment, they have to see initially, then start doing it under supervision, and then when you teach, your yield automatically improves. So what is the role of training when you come to EBUS TBNA? So this is the study, systematic review, which was done by Dr. Dhuria, which shows that with a mean of 37 to 44 procedures, you attain the proficiency and it increases linearly thereafter. And you have to do at least 10 procedures per year to maintain that diagnostic yield. So at least 40 procedures as per the IS-IAB recommendation. So this is article which was published last year in Lung India. So at least 40 procedures should be performed over minimum of 2 years to achieve acceptable yield. So there's a steep learning curve in EBUS. So what are the procedural factors? So when you're doing a procedure, you start with the ultrasonographic, examination of the lymph nodes, and then you come to the other factors. So these are the various things you look at. You look at the size, as I told you, the bigger the size, easier it is to start off. Thereafter, you look at the shape, whether it is round or oval. Margins. Malignant lymph nodes usually will have distinct margins. We can see more than 50% of the node, whether it is heterogeneous or homogeneous. Homogeneous is more commonly seen in sarcoidosis. Heterogeneous in West means cancer, but in our country, we see a lot of tuberculous lymphadenopathy, which is heterogeneous. Coagulation necrosis sign, again in West, you see it commonly with malignancy, but in our country, there is a lot of data which says that we see necrosis more commonly in tuberculosis. The central hilar structure, which I'll be showing, the conglomeration, which is seen, which is a feature of benign lymph nodes, and presence of central intranodal vessel. When you put the Doppler on, you see a central nodal vessel. The obliteration of this is more commonly seen in cancers. So first and foremost, when you're choosing a lymph node on the CT, always avoid a calcific lymph node. Because if you're trying to put the needle or you're pushing the needle into it, one, you'll not be able to do it. Two, if you push too hard, you'll break the needle, which will itself become a foreign body and very difficult to remove. So this is a coagulation necrosis sign, which in India we see more commonly in TB, in the West in malignancy. These are the central hilar structures which you see, which should be preserved. In malignancy, this is destroyed. Homogeneous conglomerate lymph node, it is sarcoid. If it is heterogeneous, more likely to be TB because of the periadenitis and the conglomeration which we see. This is a central intranodal vessel which is seen when you switch on the Doppler in these patients and which is suggestive of benign nodes. If this is destroyed, then probably you're looking at malignancy. So one sign alone cannot differentiate. So benign versus malignant, absence of the central hilar structure and a coagulation necrosis sign goes more in favor of malignant. But in our country, we see that with TB as well. In sarcoidosis, you get more homogeneous nodes with a negative central coagulation sign as compared to TB. So one sign is not good enough. And this is the paper which looks at 5 of these signs. If you have a size more than 1 centimeter, round shape, heterogeneous ecostructure, absence of the central hilar structure as it's shown, and presence of central coagulation necrosis, then the sensitivity is high. And no single endosonographic mediastinal lymph node characteristic is good enough to differentiate between malignant and benign etiologies. And it does not obviate the need for a biopsy. So you can have a good pre-test probability when you're looking at the ultrasound with the EBUS of the lymph node, but you definitely have to go ahead and do a biopsy to confirm the diagnosis. The new technique with which, for which I was also very excited and we started doing it. So these are the cases where we did elastography, which looks at the stiffness or the hardness of the node. So if it is blue in color, that means it is hard. If it is red or green, then these are softer nodes. So malignancy is supposed to be harder. So they will be type 3 as per the qualitative classification given by Izumo. As you can see here, this node has got more green and red. So this is more likely to be a softer benign node, which you see in tuberculosis. So these are some other images. So this you have a part blue, part red, and this one seems malignant because it is more blue. So elastography was basically trying to look at the firmness and based upon the strain ratio and to differentiate the benign from the malignant. So it may aid in sampling because if you have a necrotic center and it's a blue node, you're thinking of malignancy, it is better not to go to the necrotic part because then you'll get just necrosis and you'll be missing the diagnosis of cancer in that. So it has got a good sensitivity and specificity, but there are issues with it. And it does not obviate again the need for sampling. So even if you have a elastography which is looking blue, you still need to sample it to confirm. But you can get a hard node even in tuberculosis when it is calcified or a fibrosed node. So that may be a false positive elastography, and negative in case you have a necrotic malignant lymph node in which you'll find a center which is green or red. So it came with a big bang, but actually it doesn't improve the yield. It just gives you a pre-test probability, but you still have to go ahead and do a FNAC TBNA of this node. Now coming to the the technique part. So use of stillet. When we started, we used to use stillet in all the cases. It is a vac lock. The syringe, which is the stillet is the center part which is connected to the syringe outside. So we used to keep the stillet inside, and after you have punctured the node, it is very important to push the stillet. So this is a very important tip, because when you puncture, there would be bronchial epithelial cells inside the needle. And if you don't push the stillet, your sample will be contaminated with bronchial epithelial cells. So you clear it after the puncture has been made into the lymph node, and then you pull it back. Now, there are a lot of randomized controlled trials to show whether the stillet is required or not. So there's no significant difference if you look at in the cytology. It only increases the procedure time by approximately 2 minutes. So without the use of the inner stillet, there is no difference in sample adequacy. So we have to get used to, not using the stillet, because it reduces the time. And this is what the ICS recommendation also says, that the EBUS can be performed with or without stillet, though conventionally we always were using a stillet. Now coming to a balloon. Now, as you know that, whenever you have an ultrasound, if there is air, you're not able to visualize. So this is a balloon which is put at the tip of the EBUS scope with saline inside to get a better visualization of the lymph node. And especially so when you're looking at the paratracheal, especially the left-sided, the 4L, the 2L lymph nodes. And that also partly stabilizes your EBUS scope inside a larger lumen, which is inside the trachea. So there are no relevant studies which directly compare EBUS with or without balloon, but it is always a good practice to use a balloon, because it makes the visualization better. Because once you've already put the scope inside, it becomes very difficult to take it out, increases the procedure time, and then again put a balloon and put it back, though it adds to the cost. So especially for the lesions in the trachea, the paratracheal lesions, you must put a balloon for better visualization and stabilization of the EBUS scope as well. Now coming to suction, as we all know that we have been using this vac lock syringe at the end of the TBNA needle. So there are various randomized controlled trials which have looked at various levels of suction and whether there was no suction which is used. Conventionally, when we started 10 years back, we used to use suction in all the cases. But now with this evidence coming, there has been a change in our practice. So higher suction, it was thought that you'll get better tissue. But though it was at the cost of increase, bloodiness of the sample because of the suction when you are inside, and especially if you hit a small vessel inside the node. So the randomized controlled trials which have looked at no suction versus 10 ml suction, 20 ml is the usual vac lock syringe which comes with the needle, and a 40 ml suction. 40 ml, it's very difficult because it was custom made for this trial. So usually it would be no suction versus 20 ml suction. So the RCTs have looked at, so they show that there is no difference in the cytological specimen, though the yield does not change, but there is increase in tissue core. So this tissue core may be used for additional genetic markers, especially in the case of malignancy. So there was another randomized controlled trial by Castle published in Chest, which again looked at, and it said that there is no difference in cytological yield or the quality of cytological sample, but the ability to get a core biopsy was higher. And in one of the studies, it showed that it enhanced the diagnostic yield of the cell block, because more the material you get, more sediment there is at the bottom, and you can make a good cell block. So that is where, the use of suction is there. So nowadays we are, in our practice, we are not attaching suction initially. If you get a good smear, if you get a lot of material, there's no point in attaching suction. But if you see that there is, insufficient material, then probably there's a case to attach suction later to improve the cellularity of the specimen. So this is as per the guidelines. It say it may be performed with or without application of vacuum suction. So we've changed our practice over the years. Now, this is where you're using a stillet with a different role. So this is a slow pull capillary technique. So, most of the advances which we see in pulmonology actually originate from gastroenterology. And this as well has come from there, where they're doing EUS of pancreas. So they started using a slow pull capillary technique, in which when you are doing the puncture, you keep withdrawing the stillet slowly. So with that capillary suction, you get more tissue which is sucked up into the needle. And that is how the yield or cellularity increases. So this is the slow pull technique, which increases the diagnostic yields significantly in various randomized controlled trials with higher yield of tissue core. So the importance of tissue core is that, as I've told, that our pathologists are better at histopathology than cytopathology. So if you get a core, it will be a proper histopath, and the chances of getting a diagnosis in our scenario is much higher. And there was higher number of tumor cells than the aspiration method and higher success rate. So it may be used, but you have to just change your practice a bit. Now coming to the revolution part. So, various people, they have used. So a revolution is basically the agitation. So once you have punctured the lymph node, as you can see here, the number of agitations which you do, they have varied from 5 to 20 in various studies, as good as 20. But for other diseases, it's not known. So for lymphoma, should we do more revolutions to get a cell block so that we get a diagnosis? So probably we don't have the answer. But in our setting, we do, if the diagnosis is more likely to be lymphoma or a benign diagnosis, it makes sense to do more, especially for additional samples. So this is a recent paper, published by Sejal, the PGI group, where they showed that when you do, 10 versus 20 agitations for sarcoidosis, there was no difference in the procedure duration, the complications, the yield, or the gross free bloody specimens. So you can do 10 when it comes to sarcoidosis, but for lymphoma, probably I would do more, so that you get a better yield, because it's very difficult to get a diagnosis when you're suspecting a lymphoma. So these are the various needles. Now, what needle should you choose? These are the various needles which are available in the market. The Olympus ones, VisiShot, which come in 19, 21, 22, and 25 gauge. The ProCore Cook needle, which has got additional bevel tip. And now the Acquire 2 Boston, which is a Francine tip needle. So is there a case in using a bigger needle? Because a tissue is the issue. As I told, if you get histopathology, the chances of getting a diagnosis is much more in our setting. So is the 19 gauge better, which is a histopath needle? So this study by Garrison in 2018 looked at it, and it said that it increased by yield by 8% and additional HP information in another 12%. So approximately 20% yield was there. And the diagnostic yield improved from 92 to 99% when you used a 19 gauge needle. And the number needed to treat was 13 with no significant complications. So now looking at the needle size, there have been various randomized controlled trials. In diagnosis of sarcoidosis, it showed that the 19 gauge had significantly higher sensitivity, but these were all, retrospective studies. These were not RCTs, and there was no significant difference with the use of rows. So the sensitivity increased from 84 to 93% when you used a histology needle. And when it comes to cancer, all the needles had similar, diagnostic sensitivity. So for cancer, it doesn't make much of a difference, except when you're looking for a sample adequacy for molecular and IHC testing. So essentially, when you're looking at a histology, you're looking at a benign diagnosis like sarcoidosis, and also a biopsy diagnosis such as lymphoma. So those are the cases where you need a bigger needle. When it comes to sarcoidosis, there's a recent randomized controlled trial, the GUESS trial, which was published, which showed that there was no difference between 22 gauge and 19 gauge for sarcoidosis. But when I'm suspecting lymphoma, when I need a histology, I would definitely go for a bigger needle. So though the evidence for sarcoidosis, in view of RCTs, is not there, but for a diagnosis of a lymphoma, histology is much better. So these are the needles. So this is a 19 gauge. This is a histology needle where diameter is 0.69 compared to 0.41 for a 22 gauge needle. And this is the ProCore needle, which is the Cook needle, which is double beveled. There's a bevel upper, and inferiorly there's a bevel which gets the core. And this is a Francine tip Boston Acquire needle. So is there any difference in the yield when you're using the ProCore versus the standard needle? So for sarcoidosis, there's no difference in Dr. Dhuria's study. In malignancy, again, no significant diagnostic advantage, though a retrospective study showed statistically significant increase in diagnostic sensitivity when you're using a ProCore needle. But essentially, the ProCore needle does not increase the diagnostic sensitivity. That is what the consensus is. Now, coming to the other needle, which is the Francine, which I've told, which is the Acquire, which is the Boston Scientific needle. Does that increase? So initially, it was thought that a Francine tip biopsy had higher diagnostic yield, but a recent paper which is published, I think last week only, from the Ames group has shown that is also doesn't improve the diagnostic yield. So the various needles which are there in shapes and sizes, they do not actually increase, and the ICS IAB also has not given any recommendation for or against different types of passes should you make. Pass is essentially a puncture of the airway, the lymph node through the airway, till the time the needle remains inside to the exit pass. So this was an important study by Lee published in 2008, which showed that for cancer diagnosis in mediastinal staging in non-small cell lung cancer, these are the number of passes you're making. So at 3 passes, you are 95%. Even at 4, you have got 95%. So the yield does not increase beyond the third pass. So the maximum diagnostic value for malignancy was achieved in 3 aspirations. And in this, there was a significant increase in diagnostic core yield when core was obtained. Like this is the core which we get. As I mentioned in our case, also in our country, if you get a core, then you'll get a histopathology sample and yield will be better. When it comes to sarcoidosis, then the patients underwent 6 passes, and they found that at 4 passes the yield became maximum, which was 85%, which did not increase thereafter. So essentially, what we mean is, if you are looking at malignancy, then 3 passes is good enough. But for a benign diagnosis, you need 4 passes. And you may like to do an additional pass in case of non-small cell lung cancer when you want to do the molecular and a genetic workup. Now coming to the very important part, of my talk, which is the brass tacks, is the processing of sample. Because, the technique is in your hands. But when it comes to the processing of sample, this is where you need a good, cytology technician, and you need a good histopathology and cytopathology support. So how do we prepare the slide? So one is the usual practice. You take the needle out, and with the help of a syringe, you squirt it over the slide. And the usual method what we use is the press method, in which you press the slide with another slide and just smear it to make a tongue out of it. So this is the usual most common method which is used. Now, how many slides should be used? So if you have a large number of slides, we send 40, 50 slides, you're unnecessarily increasing the workload of the lab, and probably you'll not get the slide which has got the material might get missed. So what is important is that out of whatever slides you made, at least one should be air dried, because air dried slides have minimal cell loss. Whereas the wet fixed slides, which we put in the Coplix jar in ethylene alcohol, it preserves the shape and structure, but there is some tissue, there is some cell loss. So for every pass, at least one air dried and one ethyl alcohol fixed slide should be there. So this is the preparation table, where you have all kinds of, you've got the cytolite, you've got formalin, you've got saline, you've got the Coplix jar. So air dried for better, less cell loss, and for better structure, you have a wet fixed slide which we use. Now coming to the cell block, over the years we found that cell block is a gold mine. Previously we used to just squirt whatever is there in the needle onto a slide and discard the rest. Now even if you take a needle flush and then you send it in, for a cell block, it's a gold mine. It's like a mini biopsy, because they'll convert it into a biopsy, and it is processed like a mini biopsy, and you get a histopathological sample. So does it help? Yes, it increases the yield by 10 to 15%. So after you made a slide, just flush it into saline or formalin and send it for a cell block. And especially if your cytopathologists are able to make it, you'll get a better yield for genetic material as well. Do remember to send one sample in our country in saline, because this is a sample on which you'll be doing the ZN stain, the culture, as well as the gene expert. So this IHC and molecular tests, they would further add to the yield in suspecting malignancy. So just to summarize, when you get a EBUS TBNA aspirate, you can do a air dried with a DEFWIC, rapid HNE, which we do in our setting. GIMSA, toluidine blue is the pap smear. The wet fixed one, which is this one, which is our pathologists are pretty good at, because they do a lot of cervical pap smears. 10% formalin for histology, for IHC and fish. Saline, especially in our country, for tuberculosis. Do remember, for cell block and microbiology. The RPMI solution is Rose Parkwell solution for if you're suspecting lymphoma. So they like to do a flow cytometry on it. So these are the samples you must process. So it's not good enough if you do just a few slides and then send it to the lab. You should try everything. You should try. And if a core is there, do send the core as well, because they'll do a histopath on it. Many times people discard a blood clot. Please do not throw the blood clot away, because at the end of the blood clot, there may be a core. So the message which I want to give is that in addition to a smear cytology, also do a histopathology in the form of a cell block or a core biopsy, and something called as a liquid-based cytology, the cytolite solution, where a monolayer is made automatically. There are various machines which automatically make good slides. A monolayer slide are also available. So when you combine various modalities like cytology with liquid-based cytology and with histopathology, the yield goes up. So this was a study by Wang published recently in Diagnostic Pathology. The yield of histopath was 72. When you added a traditional smear, it was 68. And when you combine both the methods, the yield reached 96.5%. And you reached a similar yield with you get with histopath and a liquid-based cytology. So always try a cell block in addition, and also try to send a core if you're getting to increase the diagnostic sensitivities. So 2 is always better than 1. Coming to the last few slides, the last part of my talk, which is a rapid on-site evaluation. So initially, when we were not getting a yield, we called a pathologist because the needle is very costly. You're spending 15 to 20,000 on a needle and not getting. It's very frustrating if you don't get a diagnosis. So most of the time they say that you're not inside the node. There's no material. So you show them how difficult it is to do the process, what the patient goes through, what is the cost. So they get more sensitized if you get the pathologist on site. And in addition, you get a quick feedback. So it guides you to stop further sampling if you get, so it reduces the time. You change the site of sampling if you're not getting enough material from that node, and it may direct you to additional site and reduce the procedure time. Though it comes with a disadvantage that increases the time with the additional cost, and you need a trained cytopathologist to come over to your EBUS suite. So the rows can be on site, and what we started initially, they used to come with a microscope. Later on, their path lab was just below my EBUS suite. So one of my technicians used to run and take the slide there, and they used to tell me within 4 to 5 minutes whether the sample is adequate. You can do an on-site, off-site, and especially with the availability of the the tele facility post-COVID, the tele cytopathology also has picked up well, where you click a photograph, it is transmitted, and they tell you whether the technician stains the slide, takes a picture, and sends it to the pathologist, and they'll tell you whether it is adequate or not. So regarding sample adequacy, ROSE is very helpful. So there are various stains. TIFF-Quick is the one which is recommended by most of the papers, but it's not available everywhere. So the stain actually depends upon what your pathologist is comfortable. In our scenario, they are more likely to do a rapid H&E stain. Whether a pulmonologist should do a ROSE, actually there's a learning curve in this, but with adequate training, it has shown a concordance of approximately 80% with a cytopathologist. So if you have a cytopathologist who can come or on tele-cytopathology give you a report, well and good. Otherwise, you might yourself learn looking at these basic cells to find out about sample adequacy. So this is what the ICS IAB recommendation is, that ROSE was associated with a significantly lower need for additional bronchoscopic procedures and puncture number, though it does not add to the yield, but it should be performed whenever available. So this is the evidence for that. So a last slide regarding the newer methods. I'm aware that the next few webinars is going to be on the newer methods, so I'll not discuss this in great detail. So if you're not getting a sample on ROSE, especially when it comes to lymphoma, then probably you can go in for a mini forceps biopsy, which adds to the yield in addition by 10 to 27% in the various literature. Or you can do additional medicinal cryo biopsy with a cryoprobe, and you get a larger tissue, especially when lymphoma is there and it's a inconclusive ROSE. Or if you're going in for a second time and it is safe in experienced hands, particularly helpful in benign pathologies. So to conclude, the key takeaways which we have seen over the years is that most important factor is the expertise and experience of the pulmonologist. And then, coming to the technical factors such as, at least doing 3 passes per lymph node. And if you're suspecting sarcoidosis, do a 4th pass. And a 4th pass can also be done when you're wanting genetic material for lung cancer. At least 10 agitations per pass in sarcoidosis. For if you're suspecting etiology like lymphoma, we usually do 20 because we want more tissue. A new technique called the slow pull capillary technique is helpful because it gives you a course, and combining the various methods of processing like smear cytology with core will give you a better yield. So if you look at the assessment, you do EBUS TBNA, obtain adequate sample, fix and unfix, as I have mentioned, 1 slide each, do cell block, send a sample in our country for saline, perform ROSE. If it is conclusive, you stop. If it is inconclusive, then you need to go ahead with newer methods. Thank you, ladies and gentlemen.
That was a fantastic and fabulous talk by Vikas. Vikas, thank you for being absolutely on target, absolutely within the limits of what today's talk is, because I'm sure there are going to be cryo biopsy, and eventually there are going to be other modules which will discuss those in detail. But I think you did brilliant justice to the topic given to you. I think this is absolutely great, and congratulations to you for this wonderful talk. Thank you for being with us and enriching us all with very, very clear, simple, and straightforward messages, Indianizing them in a subsequent, sufficient way. And that brings us to the discussion part, because I think we are going to have sufficient discussion on all those things which you have raised as possibilities and whatnot. So, can I have the introductions of our panel here? So the first is going to be Dr. Mahima Bhaskar. She is a professor in Department of Pulmonary Medicine, Tata Memorial Hospital, Homi Bhabha National Institute. She is a faculty in TMC HBNI Fellowship in Pulmonary Oncology and TMC Fujifilm Asia Pacific Regional Training for Oncopulmonology and Interventional Pulmonology. She is a consultant pulmonologist at Hiranandani, Powai, Mumbai, and she was formerly cyanide like me. I'm glad to know that. I'm realizing it for the first time. And assistant professor in GSMC and KEM. So all those are on. And she has done oncopulmonary observerships in and I think that's the email address that she has given. So I think with that, I'll introduce the next one. 1 second. I'm already on, Amina. Yeah. हाँ नहीं मैं already on हूँ, please. Yeah. Okay. नहीं बिल्कुल हो गया टॉप खत्म. I'm already on. Yeah. Sorry. The second and not lesser importance is Dr. Vaibhav Chachara. He is a MD, European Diploma in Adult Respiratory Medicine, like myself. He is currently working as a principal and consultant head in Interventional Pulmonology, Max Super Specialist Hospital, Dehradun in Uttarakhand. And welcome, Dr. Vaibhav Chachara. With all his achievements, and I won't be reading everything that is going on, but at the same time, wonderful to have you on this panel.
Thank you so much.
Amina Mobashir, who is a DNB in Respiratory Medicine, IDCCM, and again a European diplomat, senior consultant in Institute of Respiratory Critical Care and Sleep Medicine in Max Healthcare. And last but not the least is going to be Dr. Vinod Chauhan, my dear friend from Mumbai, my close buddy in all the bronchology conferences that we have done. He is an MBBS diploma in chest medicine, chest physician and bronchoscopist, Chauhan Chest Clinic and Kothilabin Dhirubhai Ambani Hospital in Navi Mumbai. I think if I'm not wrong, then Vinod is one of the highest number of EBUS is done in Mumbai at this point in time, single-handedly. So he works in Chauhan Chest Clinic. So with that, let me ask the very first question to our Dr. Mahima. And Dr. Mahima, what are the patient-related factors that contribute to a sample yield oblique diagnosis in EBUS? What's your take on that?
Thank you for this forum, Dr. Nitin. Thanks for that wonderful introduction. And Dr. Marwa, an excellent and succinct talk, because this makes it easier for me to answer my questions. He's already made it clear about the difference between adequacy and diagnostic yield. So when we go towards diagnostic yield, we're looking at not adequate, inadequate, but atypical, suspicious, or malignant, or a diagnosis which is there. And the single most determinant factor from a patient point of view would be the size of the lymph node. So the larger the size of the lymph node that you see in the scan, the more the volume of tissue that you can sample, and higher is your diagnostic yield. Now, coming specifically towards tumor size, if you have a larger tumor, the chances that your nodes will come positive is more. If you have an N1 node positive, the chances that you have an occult N2 or an N2 coming positive is going to be more. And if the PET CT is also showing significant SUV uptake, the chances are going to be more. Taking the tumor factor aside, it has to be the pre-test probability in a patient which you're thinking at what is your diagnosis. So if you're looking towards a diagnosis of lymphoma, then your diagnostic yield will improve only if you use a correct medium. So you must have your RPMI medium to put in for cell culture to put in. So you must, as a clinician, know your pre-test probability to know what all your samples have to go for, where you need more cell blocks, and where do you need to put into RPMI medium, and where you need more culture. The other factors which would be determinant would be like in a smoker, they have a lot of macrophages and reactive bronchial epithelial cells, which can confuse your picture when you're reading your rows or you're looking at your slides. And the factor which would adversely impact would be if you have a lot of airway distortion, a lot of calcification either in the airways or a very thick nodal capsule. All of these will impede your introduction of the needle and impede your sampling. As Dr. Marva already pointed out, calcification in node is very difficult to bypass through and go. So these were the factors I would put in for patient factor.
I think wonderfully put, Dr. Amina. I think, sorry, Dr. Mahima, very well put, very well sort of coordinated your thought process in the terms of patient characteristics. My next question is to Dr. Vaibhav. And what is an ideal setting, the choice of an EBUS scope before the procedure to improve the yield? And do you think of using adding a flexible bronchoscope or being ready with a radial EBUS as a standard of care with most of your patients, or you're happy? Of course, I mean, Dr. Mahima has already pointed out that we are largely dealing with mediastinal nodes as the first core of choice. So I'm not too sure whether you will be ready with an radial EBUS, but all the same, I'll ask you that question.
Okay, thank you so much, sir. So basically, even when before we are starting the procedures, the CT or the PET scan, what we have would give us an idea. So definitely, if you're thinking in terms of a non-malignant disease or sarcoidosis, I would love to definitely do a check bronchoscopy first. So eventually, the take-home point should be for everyone is that you do a check bronchoscopy first. You can take your transbronchial lung biopsies, or you can take your lavage, or you take your endobronchial biopsies. Followed by, if you have another lesion which is there to be targeted first, you can use a radial EBUS if you want. Again, as I said, depends on your PET. And then end of the day, when you know the entire anatomy of the lung and when you've gone in and seen and you've done with your biopsies, then you go ahead with your conventional, the convex probe EBUS and target your lymph nodes for the staging purposes.
Yeah.
And also importantly, if you're doing your check bronchoscopy, you would be giving apt topical anesthesia, which would definitely help and in using less sedation for these patients.
So I mean, let me ask you, expand that question a little bit and say, I mean, I do that often. That I'll say, let me do a bronchoscopy first under local anesthesia, and I keep my anesthetist on the standby. And then, if I'm not happy with the yield which is there, for example, typically with a sarcoid or an obvious malignancy which is endobronchially visible, then I just take an endobronchial biopsy and I'm come out. So do you do that very often?
Yeah, I obviously would always do a check bronchoscopy first. But in case, as I said, you have uptake in the lymph nodes as well. So after the biopsy, definitely the staging procedure can also be done at the same sitting. So you take the biopsies. In fact, I had an interesting case where we had a lesion which was totally, so we did a resection and removal of the entire lesion. Eventually it came out to a neuroendocrine tumor. And we also went in through the esophageal route and sampled the lymph node also, the subcarinal lymph node. So both should be done. So initially a check bronchoscopy should always be done. We can do our basic tests, take the biopsies, take the lavage, and then go ahead with the radial or the convex probe EBUS depending on your CT findings. Yes.
Perfectly. One thing, I mean, I'm sorry, I'm spending a little more time on this particular part of it. But once you put on an EBUS scope, it's well, I mean, directing the lavage is not that easy. So if I want to do it, I will do it with the ordinary bronchoscope. Do you agree with that? I mean,
absolutely true, sir. You're absolutely right.
Yeah. So I think that becomes a little bit difficult, once you are into it. Let me come to Dr. Amina and ask her a question on this, extending this further. What are the EBUS equipment related factors that we need to be aware to improvise the yield, including obtaining a good image, whether it is elastrographically with Doppler, plus, minus, whatever? What do you want? What are you really looking for?
Right. So thank you very much for the question, sir. Good evening, everyone. So basically, the first and foremost thing to obtain a good image is to, of course, go on maneuvering and manipulating your scope till you get a nice, good capsule, a nice visible lymph node. Then, of course, we have the option of using a balloon if you're not getting a very good image. We particularly use it for a 4L lymph node. Then the next step is to see on a B mode the characteristic of the lymph node, like the size more than 1 centimeter. Dr. Vikas has already explained all of that, whether it's rounded, heterogeneous, absence of a central hilar structure, whether there's coagulation, necrosis, and all. The third thing then would be to switch on the Doppler and see the vascularity of the lymph node, see whether you're at the right place, to be very certain that you're not puncturing a vessel while inserting your needle. While we are doing an EBUS, while we are jabbing, it is very important to go from capsule to capsule as we are conventionally taught. If you are applying suction, it is essential to keep an eye on the syringe if there's any blood coming at the same time. Then stillet may or may not be used to avoid sampling bronchial epithelial cells. Coming on to elastography, sir, we have just discussed that the more blue the lymph node, the higher the chances of it being malignant. So type 1, type 2, and type 3 lymph nodes have been classified, type 1 predominantly being malignant, less non-malignant, less blue, and type 3 being malignant and more blue. So these are the various things which
I think theoretical question or practical, how many of us are actually doing elastography? I mean, I'm not doing it in my routine practice because any answers on this from your side? Are you doing it routinely or?
It depends on the machine you have. If you got the Olympus ME1, it does not have elastography. If you got the upgraded, the ME2 version, then you just need to press that button and you'll have a quick vision and you'll get a fair idea, if there is a necrosis, whether it's blue. It gives you a good amount of pre-test probability and doesn't take much time. So it doesn't just take a few seconds.
So the ME2 in Olympus is having it.
That has elastography.
That's a good thing to know for the people who want to improvise the yield. Routinely, of course, putting the Doppler on is invaluable. There is no question of not using it. So that's absolutely without any argument or controversy. Getting a Doppler. One thing I will ask all of you is, if you see a lot of blood vessels, are you afraid to put a needle or do you are comfortable? A lot of vessels within the node. I'm not talking of the bigger vessels outside.
I think there's no problem putting in a needle because
I think so. I also agree with that.
It's all magnified.
If somebody has any other say on that, please.
I think you have to know whether it's nodal vessels are very common. What you have to avoid is the bronchial arteries. Sometimes you have chronic nodes, you have massive, large bronchial arteries, which you can even see on your scan at times. So those are the ones I would say stay notoriously away from, especially if you're starting off.
You're not going to go into a large, massive vessel in any case.
But you can see the origin. You can see bronchial arteries very well. On Doppler, you can identify what you're looking at. So in chronic nodes.
Amina, can I add a sub-question to your thought process?
Yes.
You said cortex to cortex or whatever, so is it
correct.
absolute must to do that or you can get away with murder? I mean.
No. So basically we aim at that. At least, try hit the capsule, but sometimes even without hitting the capsule, you do get a fair enough yield. So that is where Rose comes to our rescue.
Yeah, and I'll ask you, all of you, because, very frankly, when we started, first 15, 20, 30 procedures, we were getting all epithelial cells and nothing else. And then we started agitating the needle, agitating the select inside. And sort of shedding it off, and shedding it off into the node and then start the pass. Is that a relevant thing or is it, because you showed a lot of evidence saying nothing matters, nothing, almost no needle size, no nothing. Whatever you do, mostly you will get away with murder. But I'm sorry to use the word again and again, but at the same time, well, so does that make a difference? Because it did make a difference to our setup, definitely, because our yield dramatically improved after we started agitating the stillet inside first and then start taking the sample out.
Actually, I would also agree. I had also mentioned that initially before you take out the stillet, you have to clean the needle. So you have to just push the stillet inside once and clean the needle and drop everything inside the node. And thereafter, the stillet may or may not be used. But the initial cleaning is very important. Another thing which you can do is you should have a good swing, as I was showing you in the video. It should be a good swing, and at the same time, to increase the yield, keep flexing and extending the lever. Absolutely. So what happens when you're doing that inside the node, the needle is not going to come out, but when you're doing that, you're sampling the whole node. As you were seeing in the video, if you are, agitating at the same point, the yield is not going to increase. But when you're doing flexion and extension of the lever,
You are
the needle is
aiming at
going to
different
move and
yeah,
so you're almost sampling the entire
different parts
movement.
of the notes. Absolutely.
Yeah.
So
Absolutely.
I think as
Very, very
Dr. Vikas has also said during his talk that probably we all are in a learning curve, sir. So the initial first 20-25 patients when we were learning, probably that would have another reason. Now it comes by default is when we do the technique, we do the agitation automatically and we put the stillet in. So that goes by default. Secondly, as he has also rightly pointed out, I think fanning can also be done, with which you can just angulate and then you can get a better sample than there.
So I'm going to put being a devil's advocate. Vikas has said that there is no need of a stillet.
No, initially
I am not very
needed
comfortable. No. I'm your evidence, not you. The evidence that you showed said no, it doesn't matter whether you use a stillet or not. And then there is an evidence with another one where there is the slow pulling of stillet makes all the difference in the world. So how do you do these contradictory evidences in front of you? How do you process it?
I've never done without a stillet, sir. I think Dr. Vikas.
I also don't do it without a stillet. Very
Me
frankly.
neither, sir. We also always
I
use
make
this.
sure that I agitate. So I think I'm sure on that those parts of it. But I think I don't want to put Vikas in a difficult scenario there. But the evidences seem to contradict each other, isn't it? One says it doesn't matter whether you use a stillet at all or not, and the other says that well, I mean, if I push it, it is better yield. All kinds of permutation and combinations.
So
And a
probably
slow
something is
slow withdrawal of a
slowly,
stillet. That
at the
means
time you agitate.
slow withdrawal of a stillet improves the yield. So that's another, that means you're putting a stillet.
Or you're
Sir,
withdrawing
for
the
new
stillet.
If you're withdrawing, you have put it in. As simple as that.
Yeah.
Sir,
So,
Nitin, sir, I'll answer that question.
Yes, please.
For the beginner and newcomer, better to go with the stillet, and the trained people like Vikas sir can go ahead without the stillet also, because new beginner don't want to waste their puncture.
So Vinod, I have you on the stage. I mean, in the center stage. So let me ask you a question on what kind of sedation, what kind of airway conduit, and whether you prefer a oral or a nasal route to improve the EBUS yield. We are not talking of doing the procedure, but improving the yield. So what do you prefer?
Sir,
Oral nasal, sedation, and what kind of airway conduit? LMA, tube, what do you want? What is the best?
Thank you, IAB and Nene madam, for giving an opportunity for this. So regarding the sedation, better to do under the sedation that will help us in a yield and good sampling during the procedure. If patient curve, that may create a complication and may hurdle to take a good sample. Regarding the oral and nasal, the yield will be the same with both the route, but the nasal route can damage the nasal mucosa, that can cause the epistaxis and can cause the trauma to the nasal cavity. In case any oral pathology like malignancy, the people who are doing the more malignancy work like Mahima ma'am in the Tata Hospital, if there is a oral pathology, they can choose the nasal route. But in our practice, we are doing in a non-onco over, so we are preferring mostly oral route with the mouth guard. Very often, very less likely we are going through the nasal route, but it is not different with any of the route. And regarding the airway, the supraglottic airway, endotracheal tube, or the rigid bronchoscope. So in Western countries, most of the people are doing with the rigid. In our setup in our country, we are doing with either with the eye gel or directly without the airways with the mouth guard only. So I'm doing my most of the procedure in people with the eye gel only. So that will help us to sampling with the paratracheal nodes in a paratracheal nodes with the endotracheal tube and digit, which are not doing. I'm not doing oftenly, but there is a restriction of the paratracheal biopsy, and the procedure time is increased. Sometime I did one or two patients on the endotracheal tube, which are because of some reason they intubated, but I may not able to was sampling the paratracheal. So subpanel is the best for them. So sedation and moderate or general anesthesia is okay. The yield will be the same without any sedation. nasal route or oral route, both are the yield is the same. The depend upon the operator experience and the accessibility. If there is a oral pathology, we can go ahead with the nasal one. And the supraglottic airway IGL will be the better option in the current scenario.
Yeah, so I
And
think
it's
let me
good.
extend this question to everybody and say, are we preferring LMA versus just deep sedation, or do you want an LMA in place? So what is your choice in general? I generally do not want a tube because I mean it is mostly not necessary. A deep sedation is good enough, but most of you are you using just a deep sedation with some kind of a airway protection, or is an LMA a mandatory process for you?
In my setting, what we've been usually doing is depending on the age and comorbidities associated with the patient. Now, in case if it's a cardiac patient and you need a more depth of anesthesia where it'll be more safer, in those cases, I've been preferring iGel. And I also pointed in one of our patients, what we did was the patient was, for example, intubated and a small ET tube was there. And we have a subcarinal. Why not go through the esophageal route? Can be one more possibility, which can be thought of. Or with moderate sedation with fentanyl and midazolam is what we've been doing. Earlier days, we used to use pentazocin with phenargan and midazolam. So itself, it was to be done in the bronchoscopy suite. So depending also on the clinical condition, the age of the patient, the sampling, the type of the nodes, what we are targeting. So example, if it is a smaller node, you have to go on 4L. So obviously a deep sedation would be preferable, that we don't want the patient to mobilize. So in that case is iGel would be preferable. I have not used much of LMS though, but I'm quite happy with iGel, moderate, or sometimes the esophageal route, depending on the situation and the comorbidities associated with these patients.
I think I take the point. I mean,
Nitin sir, I have
any other thoughts on this? What kind of sedation?
Actually, small nodes and difficult location.
Yes.
If you look at it,
That
where you
question
want
is
the
to you
patient to
only
be.
in any case, because next one. Yeah.
Sir,
Small nodes.
I have one. I want to share one experience. The
Yeah.
thing is that if we go with the deep sedation and oral mouth guard, and if we go with the eye gel, because as you mentioned, I am operating alone as a physician, chest physician. So the thing important, as soon as take out my needle, I have to go for the sample preparation. If I go with the mouth guard, I have to scare about the scope damage inside the. So someone has to take care of that. If I gel in place, I am sure that I can prepare the sample with the important things. So that is the practical approach to go with the iGel.
Yes.
It's my
In
personal
fact,
experience.
if you are a single operator, no problem. If you have a bad junior, it is worse, because my scope was broken by a bad junior. So I was better off having nobody to help me, but then a bad junior was even worse. So I think because the needle is not, and I think we'll come to that eventually. Better needles and things like that. But because we were on the small nodes, so what's your take on very tiny nodes? Comparatively smaller. 7 mm, 5 mm, something like that.
So when you're a beginner, you will be very disheartened when you start off with small nodes. So as you climb up the ladder, probably that is the time you should look at sub-centimetric PET positive nodes. Because PET positivity is not always malignancy. So even if you have a node which is 8 mm, which is PET positive, you need to sample it. So if it is a 4L or a 2L, which is kind of 8 mm, these are the patients which are very difficult, and you need the patient to be absolutely quiet. So this is where I'll go ahead with the LMA. Otherwise, most of the patients we are able to do with moderate sedation with little bit of combination of Fenta and Midaz. And you can easily get away. Yeah, Tiva kind of a thing, which you can yourself do. But when you go into deep sedation or GA, you need, the cost adds up, because then you need an anesthetist who has to be there to monitor the level of anesthesia, because you're yourself so busy, managing these small nodes, getting the right puncture and material. So that is the time, I would use kind of a deep sedation and general anesthesia. And, the problem with the endotracheal tube is that, once you put a tube inside, it is already covering your paratracheal nodes. So you have to withdraw, come back to the vocal cord. So it becomes difficult. So
2R becomes a little bit of a problem. So you
very
have to
difficult.
come back
LMA that way.
and then the cough is the issue. So I think there are multiple issues with that, I think
the second generation
LMA
of LMA is now available.
LMA is
Those
the
are
max I have gone to, and very occasionally. Mostly I do get away with Tiva, and that is good enough. So I think if there is any other thought process, otherwise we'll move on to the next question for Dr. Mahima. And this is something where you're suspecting a malignancy or a staging a malignancy. How do you proceed to get the max yield? And I think that 2R point is also relevant. But at the same time, and the role of molecular testing from EBUS samples?
That's a good question. So when we do staging, the most important thing is to know is you start from the N3 node.
Yeah.
That is the opposite side paratracheal node.
Yes.
We're not taking the supraclavicular. We're talking about only mediastinal nodes. So the
Yes.
opposite side nodes, all of them are N3. So start with the N3, then move to the N2.
Yeah.
Even if you get one N2, that's not enough. You have to see if it's a multi-station N2 or a single station N2, because the new staging also it impacts the prognosis further. And then you go on to doing N1 if you have to do SBRT. If it's an upfront surgical candidate and the N1 is going to come out, you're fine. But otherwise, you will, if that's surgery plan is plus minus on it, and there is a possibility for a negative and may not be medically off, then you will go and proceed and even sample the N1. Because if N1 is negative and the lesion is amenable to SBRT, then you can kind of do that also. So you're finishing that in one go as well.
Yeah. There is a top question to what you said.
Yes.
How many times are we really doing the staging procedure in the true sense of the word? I mean,
I am so being in a cancer staging, but yes, I work in the so I'm in a private practice also, and yes, practically in my private practice, the amount of patients sent for staging is very less, practically less. The medical oncologist sees the PET scan, looks at AVID, declares that it's positive, and goes ahead. So very less, and plus the cost of an EBUS in private practice and the cost of 1 month of TKI. Let me put it that way. That's what most patients come down to calculating. So that's the practical thing.
Is necessary.
Yes, the balancing act is necessary.
And the issue of let me ask everybody the wonderful idea of doing 3 passes per node. How realistic is that? Because I rarely do 3 passes per node, very frankly. I mean, the max that we stop it is 6 or 7 total passes. And of course, we have a rows in the sense my laboratory is 7 meters away from my working station. So 7 meters is not much of a difference. The first pass goes, second pass goes, every pass is going to them. So adequacy is established. So are we realistically able to do 3 passes per
We do. So that's why when you were asking about, which sedation would you use? So in a staging procedure, I am going to do 3 plus. I am going to do 3. If I have to do molecular testing, I'm going to go ahead and get more material, give it all for cell block, because I'm going to need that for PDL1 as well.
In a nutshell, you end up doing something like 20-25 passes.
Yes. So therefore, our patients end up with a more deeper sedation. Plus, when it's a longer procedure. And sometimes we have 7 stations to sample in a patient, right? From any 3 up to there. And it also depends on.
It's a grueling task.
Yes.
Isn't it?
So you have to count the time of procedure, number of stations, who's doing the procedure.
Yeah.
What's the indication? So most private would be diagnostic mediastinal adenopathy. So it's 1 or 2 stations at the most that you're sampling, and that's a fast procedure.
3 passes is not a problem per station. That's not a really.
Yeah.
Any other thought process on this? I mean, anything else on
your
this?
second question was on molecular testing, I believe.
Molecular testing, yes.
Absolutely. So the molecular testing, you can do it on EBUS. The PDL1 needs core. So PDL1 needs core. You need to have minimum 100 cells for your PDL1 to be able to accurately say what's your PDL1. At least 100 cells. So if you're one cell positive out of 100, that's 1%. That's pretty much that way. You have more, great, but it's 100 minimum which is needed, and you need to send at least 3 cores for PDL1. The EGFR and ALCross can be done on cytology, but Ross IHC has to be rechecked with a FISH or an LGS. So you can do with cytology also, but then you need at least more than 20% cells on your slide should be tumor cells. And if you're doing a cell count of all your cells on slides, at least looking around 300 to 400 cells. So that's why the more passes is helpful. Putting into a cell block is far better because you can run your NGS and everything far better. You get more cell count.
Perfect.
So we look at our rows. A pathologist looks at the first one, tells us you got good, you're in the right place, you got a good amount of, just take more cores and put it into cores. That's easier.
Is there a technique of getting more cores in your mind? I mean, it's for everybody. It happens rather than it's intended, according to me, with the standard technique, isn't it? 30% of them are cores, and you look at it and say, "Oh, is that a core? Wonderful." But was that not a core? It's not in my control most of the times. Is that true, or
It depends on it. If I
somebody can
don't get, I will explore other parts of the node. So you
absolutely.
actually cover the width of the node. That's the
Yeah.
best way to do it. And so the part where you start getting good material, you get it and you see it on your slide, that's the site you're going to go for more. We don't have an elastography there, but it's not affected our yield. We have a 92% concordance with our surgical staging of EBUS with lymph nodes more than 1 centimeter. So we've been doing fine without an elastography as well. But I'd say the more the nodes you do, the more experience, the more likely you're here.
More likely.
And for people who are preparing slides, if you get a nice core on your slide, don't sit into a crush artifact. Pick it up and put it, triage your sample valuably, rather than doing a crush artifact and getting everything enmeshed in blood.
Absolutely. Particularly for small cell, it is a killer. Absolutely. Because you wanted to add something, please.
Yeah. So I think when you're using the 19 gauge needle, you get more cores.
Yes.
So when we were doing more of 21, 22, the cores were not great. But when you come to a histology needle, anything less than 20 gauge, the 19 will give you a good number of cores. And that is why probably, the cell blocks are much better when you're doing a 19 gauge.
Yeah. So if my suspicion is lymphoma, we'll ask for 19 gauge needle, because you are looking and you want to kind of get more cores.
I think we'll come back
most of our time.
Little ahead. I think let me ask Dr. Vaibhav, does more suction result in a better sample, number one? And do you do suction as a standard of care routinely or not? And how many agitations per pass? I mean, 10, 15, 12, 20?
I think Vikas sir has already mentioned in his talk beautifully.
The evidence.
Where he showed the evidence from the AIMS team, where around 300 or 400 patients were sampled, where suction does not play for improving a better yield. But definitely the acquisition, as he rightly pointed out, of the core tissue was a shade better with suction. I'm quite happy with the non-suction, but as he's also rightly pointed out, like if you do 3 passes or the 4th pass and you see you're not able to get that core, you can apply suction in one of the patients eventually. And I think the passes, what you said, is already shown. For sarcoidosis, he said that was the 4th pass, which was yielding as high as 85% or the 86% mark, whereas the first pass was somewhere around 65. So yes, we take 3 passes or 4, or as you yourself were talking about, that you tend to take 6 to 7. I'm happy with 3 to 4 passes. I think that's the one which was. And I think during that period, if you do a rapid on-site evaluation, sir, you have the same amount of time which is being sent. So when you are on the 3rd pass, I think by that time you already got it.
You already know whether you are adequate or not.
So the rapid on-site would definitely help you in the lower puncture rate. I think that's also a proven fact.
Very, very frankly, the cytopathologist I deal with is a very depressed individual, and mostly she keeps on saying, "Sir, ज़्यादा कुछ दिख नहीं रहा है, lymphoid cells fine," but I am not able to conclude. And finally, the end result is great, because the senior histopathologist sees it, and the yield is great. But the first person you encounter, and this is a practical problem I face all the time, that, well, I mean, most of the times we ignore her and bypass her.
So I worked with Dr. Goyal.
The so-called ROSE becomes a rapid on-site depressive methodology.
So then that's why the advent of PROS was there. For me, the debacle is that my pathology lab is 2 floors down. So the GDA staff is just standing outside. So eventually, as the time has passed, now we've learned that PROS.
So how many of us are doing, we are six of us are here, 6, 7. How many of us are doing PROS in the true sense? You are doing wonderful.
Yeah.
And is that a rewarding thing? Is it worth spending extra time on it or not?
I think it's worth it, sir. It's definitely worth it.
Yeah. So I think the message should go out to everybody, saying that, look for the adequacy. We are not going to diagnose it. I mean, the diagnosis is a pathologist prerogative, but I think just getting that extra information that the sample that I have taken is adequate. I'm not looking at the final diagnosis. I'm not trying to be pretending what I'm not, but at the same time, I think the adequacy of the sample can be verified by a good PROS. The PROS is not a bad idea in that sense. In that sense, I would only reserve it for just the adequacy of the sample rather than the final diagnosis. Final diagnosis is definitely the pathologist's prerogative.
And in fact, in my center, again, if it's the senior pathologist, she would be saying 4 slides se upar nahi. So we eventually do not send, and end of the day, I'll end up sending her so many slides. So it's the junior one who says
50
always
slides.
that yes.
The minimum we send is 50 slides.
Yeah,
And,
it seems with me.
very frankly, I'm worried if I have 1 or 2 slides coming out of the first sample, then I think I'm not doing enough. So I think that's the problem, because the typical TBNA yield is very good, and 7-8 slides are easily made out of one. So generally, yeah, that's the story. Of course, I
Actually,
mean,
we also started doing that, but now what we do is after 4-5 slides, we'll squirt it inside and make a cell block. I
make
think,
a sense.
adding a
Exactly.
different method rather than sending 8-10 slides, 3-4 slides every pass, and add
then
a cell block to
for the
it.
rest of the
And if you
rest of
go,
the
so you
things.
get a better yield
Perfect.
by combining the methods.
Perfect. Because the
I
whole
agree.
story
And
is one
I
go.
mean, Nitin, I don't know in yours, but in my private practice, they bill by the number of slides.
Oh my God. Okay.
So I actually started doing this. To couple of slides, one air dried, one wet, couple of them rest all in cell block,
And
because
the
cell
rest
block
all
is
in
billed as one.
wonderful. Yeah.
So it's better.
And a saline sample is the most in most of the
And
And
private.
there is an incremental value as you do more passes, as you asked. And I think you need to give more samosa and chai to your cytopathologist to sing your saliva.
So I'll come to Dr. Amina. This is an interesting one. What is your choice of needles to increase the yield? I think we have already discussed 19, 21, 22, 25. So all kind of ranges available. And biopsy or oblique needling techniques which can improve the yield.
Right. So first of all, just about the previous discussion that we were having, before we start an EBUS, we first find out who's the pathologist. And based on that, we estimate the time that we're going to take. Because, bronchial epithelial cells and inadequate sample and all depends sometimes on the mood of the pathologist as well. Coming back to the needle size and shape. So we've discussed enough, sir, that the 21, 22 needle size, there's no difference in the diagnostic yield.
Absolutely.
Some would prefer the 19G for core sample, for lymphomas, for sarcoid. Some users also prefer the 19G needle if you're planning to do a TBCNA or a core biopsy to create that tract. However, in our practice, we've been able to do a cryo biopsy through a 21G needle created tract as well. Now, as far as the shape is concerned, sir, the Procol, Fanson tip needles, again, there is no evidence, that says that there is a significant difference in the diagnostic yield. Coming to the technique of jabbing, fanning is one option, as we were discussing, moving the scope and trying to cover the entire lymph node. But again, there is no evidence that there is an improvement in the diagnostic yield. The only thing which, again, Dr. Vikas had mentioned initially, which we had a discussion on, is the slow pull capillary technique that you gradually go on withdrawing the stellate, and that can, sort of increase the diagnostic yield. The one thing which we always follow is that we try and use a new needle for every patient. So that is one thing.
Yeah, that gives you the sharpness and the penetration, and then the adequacy sample may be improving.
Right, sir. And then again, you can add a forceps biopsy as an option if you need core. Then TBCNA can be done. There's a recent study in 2024, only a meta-analysis from AIMS that says that TBCNA improves the yield. What we usually follow, sir, is that if we are getting something on row, say, for example, if you're getting a granuloma, necrotizing, non-necrotizing granuloma, we would just take the microbiological samples and stop it at that and a cell block. However, if we are not getting something on rows, if we're getting, say, a reactive lymphocyte, then we go ahead and do a core biopsy. Nowadays, we mostly do a TBCNA, a cryo biopsy from the node, to get more tissue. At the same time, if we're getting a malignant malignant cell positive on the rows, then again, we want more tissue. So we go ahead with all the cell blocks and the cryo biopsies and all. So that's what we usually do.
The cryo, I'm leaving it for the other, next module. So I think we won't go too much into the depth of it.
But sir, a word of caution that I'd like to add here is that because recently we've had, a bleed while doing a lymph node cryo biopsy, because you have to be very careful that the lymph node is not very vascular, and if you're inserting your cryoprobe at the right position.
Correct. Because the cryo works 360 degrees.
Yeah.
So it's going to get an adjacent vessel also into, and therefore one has to be a little careful. But I think we'll leave it for the next module possibly. Vinod, this is a question for you. I think this is more of an extension of what we have asked Amina. In a case of a suspected lymphoma, which is possibly one of the most difficult to hit kind of diagnostic situations, what is the ideal place to take a sample from? And do you use any add-ons? I mean, do you do this? You may get into a little bit of cryobiopsy if you want to, or a mini probe.
Yes,
Yes.
totally agree, sir. This is little difficult to diagnose as we are doing the routine EBUS, so we are not trying as much beyond our boundary. So with the small 19 gauge or 20 gauge needle, we can try to get a bigger chunk. And with the fanning and jobbing technique, we can move the scope and we'll needle inside the node. That also we
Absolutely.
can
So
do attempt.
different places can be sampled. So I think,
Yes,
as Vikas very rightly said, so you
yes.
don't have to
And
only aim at, you keep changing the direction and you get more angles and you cover more areas, I think. So that probably will increase it. Of course, cryobiopsy is a different game altogether, and I think we will come to that in another module eventually. So let me move on to Dr. Vikas and say, do you have a straightforward so-called suspect case of TB oblique sarcoid? Are you good enough with an EBUS alone? Or do you need more biopsies? I mean, what's your overall experience on this?
So if you are suspecting, TB versus sarcoid, so as I mentioned, you need 4 passes if it is sarcoid rather than 3. Because again, you want, it's a histopathological diagnosis. And
Correct.
unlike cancer is easier, 3 passes is good enough, 4th one is for genetic material. But sarcoid,
Yes.
at least 4 passes are required. It may be 4 from one node, or it may be 2 plus 2. If there are 2 nodes, you do 2 passes each from a node. So that way it adds up to 4. And also you should send some microbiological sample, because you may get a granuloma at the end of it, chronic granulomatous inflammation. So you're nowhere. So what you want is whether it is gene expert positive with a culture or AFB. So in that case, you must send a sample in saline and try to differentiate between the two. So just by EBUS, you may not be able to differentiate. There has to be clinical features. You have to have MONTOs. You have to have CT scan, necrotic nodes on ultrasound, heterogeneous, conglomerate. So all other things have to fit into it. So it's just not a chronic granulomatous inflammation. So, microbiology adds there.
Well, I mean, I think I'll tend to agree with that, because you have to combine maximum possible techniques, and I absolutely agree that 4 passes is relevant, because differentiating between a caseating versus non-caseating sometimes on a needle sample becomes a little difficult for the pathologist. So I think absolutely agreed on. This is a little cryptic question to Mahima, Dr. Mahima. What are the pre-procedure and intra-procedure techniques will you use to increase your yield in a case of ILD or a COPD who is hypoxic? I mean, somebody who is not so stable.
You'll have to unmute, madam.
I'm wondering if this is a question or a trick question. Okay.
It sounds like a trick one. Yeah.
Yeah. So if you're looking at resistant hypoxemia, severe hypoxemia, that's a total no. Okay. So we're looking at mild hypoxemia, which I'm able to correct with a bit of oxygen, whether it's an ILD and COPD. And let me go first the tumor way and the non-tumor way, both way. So the indications for me to do an EBUS in such patients will be very limited. It's either because they are definitely non-metastatic. They don't have anywhere else. They have the only site of diagnosis possible for me is mediastinal node, and that's about it.
Absolutely. If I have an axillary node, I would be doing an EBUS in such a patient.
Correct. Or I have to plan an SBRT because the lung capacity is very less and I want to do maximum lung saving radiation, and that's the reason I'm doing it, or I'm doing a restaging. Okay, so these would be my limited choices in oncology for me, where I would be doing it. In which case also, I would first look at if there is a node where I can go it without a shared airway. So if I can sample a node, which I target node, like it's 7 station 4L or a very large 4R, that can be done via EOS and not have a shared airway, then I'm very good. That reduces my airway risk to the patient. So that's one way to go. Okay. And the next thing would be, what would I do for the patient pre? So if it's a COPD patient, an anticholinergic, optimize the COPD, it should not be an exacerbation. Obviously, we're talking of a stable COPD or a stable ILD who is a mildly hypoxic. So the bronchodilation should be optimal. It should be an optimal management. An anticholinergic nebulization, which will reduce the mucus in my airways, as well as help me from bronchodilation at that time. anesthetized well, because I'm going to touch the airways, so I don't want to trigger too much bronchospasm. And I would prefer to be in control of the airway. It would depend on control of the airway rather the other way around. So either endoscopy mask NIV or a supraglottic airway, in which case I can control, keep them on spontaneous or intermittent ventilation, depending on how I'm monitoring my ATCO2s in the patient. And that's the way I'd go. And monitor the CO2s as well as watch my sedation. So I may not go deep propofol because you can have a lot of hypotension and hypoxemia when you give propofol suddenly a lot, but maybe mix the propofol with Dexmet and get a better combination for my COPD patient. Haven't had great success.
A question on this Keta, because many of my anesthesiologists are more comfortable using Keta in this.
Yeah, I mean, okay, it's a combination you're looking at.
It has got a little bit of
Bronchospasm. Yes, it's a breed bronchodilator. I was just coming to that. Correct. So in our institution, this is what we normally go for, and this is how we go. But ketamine is a pretty good thing. I would not go for a pre-medication like Midas, because I want to have an effective slow, and this way in these patients, that's what I do. We have tried doing only with HFNC, but what happens is if you're going transoral, you lose that CPAP pressure, which happens when you give a HFNC.
Absolutely.
So if I had to, it's the supraglottic airway preferably. If I have a limited mouth opening in the patient because of oral CA or whatever, then an endoscopy mask, which has a port in which also I can go through as well as same time give my ideas.
Maintain an adequate peak if that's
Yes.
Now, Vaibhav, this is where you are going to be invited on the biopsy part of it. I mean, cryo, yes, no, data. What do you think? Whole idea of cryo.
So I think histology and biopsy together. I would just think in non-malignant conditions where I think in case of sarcoid or lymphoma, two such situations. So I was always banking on my rapid on-site evaluation. There have been a lot of data there. There have been studies. In fact, a recent one just published in January in Respiration also suggested. So where they have compared EBUS TBNA with ROSE, which were non-diagnostic, there was an additional yield with the forceps biopsy, yes. But that was only a 16% additional yield, whereas out of those also the ones which were diagnosed around 50 to 61% were non-caseating granulomas. So I would feel, sir, in non-malignant conditions, this forceps biopsy where you put in the 19 gauge first and then take a biopsy, or you convert it to a cryobiopsy where you're putting that 1.1 mm biopsy needle. But as Dr. Amina also rightly pointed out, we need to look for the bleeding there. So yes, it would definitely score on the size of the tissue chunk what we are getting. But end of the day, only for a certain subset of indications, not exactly for each and every patient we would think of. So EBUS TBNA with ROSE would be there, which would be the one which would be a golden one. If you're not getting anything on the rapid on-site, you can think of forceps versus cryo. And also, yes, so there was an interesting study again where we had around 150 patients, which I said was recently published, where they did a vis-a-vis forceps biopsy versus a cryo one. The advantage of cryo down there was, one, it was a bit faster, as I said, and it qualified more for those tumor testing, the PDL1 and other ones. So that was a shade advantage. I would say that.
So probably the availability of the mini forceps is the issue.
Yes. Please come in. Because you had.
Yeah, what I was saying is that most of us would have already a cryo with us, and getting this mini forceps for the intranodal forceps biopsy is the issue. So where do you get those mini forceps? And it also adds to the cost, because
there are just 3 companies which are there, which is I think Olympus is already procuring one, which is the mini forceps is around 0.7 mm the biopsy chunk size, even that's quite small. And the other one is the SpyBite and the Core DX. They're very small. They're 0.5 the chunk size. So as Vikas has also rightly pointed out, I think after the 19 gauge, you can go in with a cryo probe inside. But I would like to say, sir, because we have students, we are all learning. So eventually do your EBUS TBNA with ROSE, absolutely rightly. In such cases, specifically when we are thinking in terms of lymphoma or in terms of sarcoidosis, but I think even in sarcoidosis, if you are doing the transbronchial lung biopsy, also endobronchial biopsy, specifically in case of lymphoma where you think that the yield is low and there's no answer to it, then we can think of these add-on procedures, would be my call on that. So let us learn the basic ones right rather than getting into the complicated ones.
Correct.
Absolutely.
So I think let me combine the next two questions in one go. I think Dr. Amina and Dr. Vinod, these are two questions in one go, and then one after the other you can go on in. What are the preparations that you do for a sample processing before an EBUS? Do you do that? What common sample types that you collect during a routine EBUS procedure? That's one. And the second question is for Vinod, but I think both of you can exchange this. What constitutes an adequate sample for cytopathology on spot without looking into the microscope? Are you able to decide that? And too thick a slide, press and feather technique. How do you fix the slide? So we can start with you, Vinod, and then we can go back to Amina. Either ways, it doesn't matter. Whichever.
So the tissue is the issue. So the procedure we are doing for the tissue only. So once you take a biopsy or then put out of the needle and then go to the your sample processing site, just put something on your slide. If it is coming pus, make a dry slide first, most important, because pus indicating the most likely tuberculosis. Make a dry slide. As and Dr. Vikas mentioned, you have to make a wet slide also. If you are suspecting tuberculosis, only the pus is coming, then just push all the things into the saline container or dry container for the microbiology. If it is the any you are suspecting malignancy, you are not getting the person, you are getting the reddish color on the slide, then just push the some saline or air in the needle, and if it is core coming, just take that core and mix it, take in the formalin, and remaining as mentioned, the many of us mentioned the slide limitation. Better to go with the liquid biopsy. That is the more useful for us to diagnosis. If 5 slide is enough for the diagnosis, if you are a good pathologist, had a proper discussion with him, his train you are doing regularly, then 5 slide is enough. Make a dry slide, wet slide, go for the microbiology. More depending upon the city finding clinical history, you have to target which sampling is important for us. Yes, Rose, we are not, many of us not doing routinely, many of us doing routinely. If you're suspecting the malignancy, definitely go for Rose sampling. Many of us having the facility of the pathologist in and around. I attended one of conference last week only. There was the WhatsApp Rose. That is also new technique. You can prepare the slide and go for. But depending upon the clinical history, city finding, and what you are getting the sample, you have to proceed for the sample. If are you more keen toward the microbiology or more keen toward the immunohistochemistry? Definitely go for, if you are suspecting malignancy, you have to try for the IHC sampling.
Absolutely. Amina, the first
So
part.
pretty much, yeah, he's answered actually both the
Almost,
parts pretty
yeah,
much. So
because
you would need
for
yeah, you would need the slides, you would need the containers, one formalin, one for your microbiology, the saline, and then of course the quality of the sample that you're getting on slide, you see all of that, and what you're suspecting based on the CT scan, you decide what all samples you need.
So I think the remaining questions are mostly been covered. So I'll go to some of the interesting audience questions and ask one. I mean, everybody is on in this. This is Dr. Madhavan from Bangalore. He's saying, what strategies can you employ when you are encountering a difficult anatomy or technical challenges? I mean, do you come across these? I think Vikas alluded to 4L, which is not a very nice station to look at. This most of our things are, for right-handed people, the 4L is a problem. For left-handed people, 4R is a problem. So I think, one way or the other. So any techniques that when you are encountering difficult anatomy or technical challenges?
So difficult anatomy can be assessed initially when you've done your basic bronchoscopy there, and then you realize that that will be a shortcoming. So eventually, rather from a mild sedation, you can shift over the patient to a deeper conscious sedation, or you can shift on the patient to an iGel. So when the patient is totally sedated or on TIVA or on an iGel or an intubated one, then you can target your lesion. And as you rightly pointed out, sometimes shifting or just jumping around the patient might help. So for example, for 4L, I can just shift somewhat on the right side of the patient, so the
Right side,
anterogyne
and
would
then,
be
L becomes more visible. And
that can be done.
unfortunately, it is between two big vessels always,
Yeah.
4L.
The Mickey Mouse
That's
sign, you can see that.
Mickey Mouse.
Yeah.
Anybody else has anything to add to this? The other very relevant question I thought, very relevant, by Dr. Saurindra from Howrah. How do you reduce bronchial secretions while doing EBUS one way or the other? Do you have strategies? I mean, do you give glycopyrronium on routine basis? I don't do that, but do you do that?
You
Is
just
it
need to
relevant?
do a proper suction. If there are bronchial secretions before
Yeah.
you puncture, you just need to do a good suction, and
Absolutely.
thereafter, I think bronchial secretions can be taken care of. And whatever, as we mentioned, is left inside the needle, that you got to clean with your stillet once you're in it.
Absolutely, absolutely. So, that's applying the suction vis-a-vis making sure that you're not getting too much contamination. These have to be balanced with each other. So I think the needle needs to have a stillet. According to me, at least at this point in time, I am not very comfortable without a stillet, because the stillet protects my entire track, and then whatever comes into the track is a good sample, as long as I've agitated. So I think that's been the common Indian methodology of thinking of maximizing the sample, because we dealt with 25 odd first samples where only epithelial cells were reported. And then all of a sudden, when we started agitating and, protecting the needle very well, things improved dramatically. So I think that was the story. Of course, we also shifted to rows, and the rows also added a big advantage, no question about it.
So also, as sir, if you also remember, like if you take the sheath out, so we ensure that is also protected. So you just see the tip of the sheath while you are going in, and your scope is in the neutral position, and then you show. So there are lesser chances also of getting those endobronchials.
Of getting a contaminant. Absolutely.
So the sheath should be also slightly seen just before entering in. That is also an important take-home message.
Nitin sir, can I add one thing?
Yes, please.
Nitin sir.
Sure.
Sir, as Dr. Vaibhav mentioned, the check bronchoscopy, the use of the check bronchoscopy is to just see your airway, and whatever the secretion in the patient of the more secretion, they can suck the secretion with the during the check bronchoscopy. And the good idea, practical way is, if you are targeting the visual node, you are knowing that with the help of the CT, you can just see your bronchoscopy, the visibility is good. You can see the site of your puncture easily, and you can see. But there are two different EBUS scope. One is having less visibility, but the other one has good visibility. With the check bronchoscope, you clean the secretion, you assess your site of puncture. That is the helpful. That is the practical.
Absolutely. Great. I think because you seem to have collected some fans around, so Dr. Gaurav from Dehradun is asking you a pointed question. Wonderful presentation. So what is your experience? More passes or a smooth hand swing? Well, I mean, of course, of
So I
course,
have
and
already
sixes
mentioned,
are hit with the middle of the bat. So I think middle of the bat or a lot of effort. So that's number
Helicopter
one.
shot.
Yeah.
So actually, the hand movement is more important, I would say. Once you're trying to look at the node, so many times you may not flex, you just need to, do a lateral, medial, lateral, movement to get the node in the center. So, a proper visualization, as, somebody just mentioned, with just a smooth movement of the hand is much better than doing more passes.
Absolutely.
Beyond third, fourth
And
pass,
a
it doesn't
question to
help.
that, you alluded to the center. So in Indian scenario, do you hit the center or you go into the periphery of the node as well?
So that's a very good, very tricky thing.
Very
If
tricky.
malignancy, you won't like to go to the center.
Same Gaurav from Dehradun, yes.
Yeah. So if it is malignancy, you never like to go to the center because you'll get necrotizing lymphadenitis, very suspicious of malignancy. But if it is TB, then you might aspirate some caseous material and you can send it for
And you
gene
get
export and get
rich
answer.
material in AB and whatnot, gene expert.
That will be rich in AB and you get a positive gene export. So that
it
again
depends on
depends.
the pathology. It depends on the pathology, what you are suspecting. Well, one more question, which is of course not so very relevant, but I think I'll ask it here, Dr. Dev from Ahmedabad. How can you integrate with other imaging modalities, for example, fluoro or CT, to enhance the EBUS techniques and yields? Do you really encounter this? I mean, I don't encounter this in my practice, but do you use, any of you uses this? So I thought it was an interesting question, therefore I'm asking it.
I guess more of use, so if you're doing a
Maybe.
conventional TBNA, you could, take the help of your radiologist friend, CT
Conventional
simulator and all
TBNA,
that.
yes, yes. Yeah, I think
Distance.
we had a question on CTBNA and improving the yield in CTBNA, but I think that is now more or less a technique which is passé rather than
Absolutely.
yeah.
Yeah.
So if you don't have anything else and you are using a CTBNA, then using the CIAM or whatever that you are having will be a great idea. But I think otherwise I would reserve it for my radial EBUS and whatnot. I mean, so there the applications are tremendous, no question about it, because the tool in lesion technique is very, very important in that, and I think we will eventually come to that in another module. What are the best practices for lymph node sampling and tissue acquisition? This is Pratik from Gurgaon. I think we have answered this, isn't it? Mostly we have addressed this question. Any additional thought process on this, please? I'll also read one more question from Dr. Raman from Bhopal. What emerging technologies or techniques are likely to enhance EBUS yield? So is there something in the horizon which will make EBUS a better thing? Like Procore, like, so many of those things have been there since 2017, but none of them has really changed the game. So it's none of them has been a game changer except cryo. And of course, cryo is not a conventional EBUS technique, but a much bigger biopsy sampling technique. So I think anything else?
Elastography, Vikas sir, would that be a game changer now?
Elastography for everybody?
Elastography only gives you a pre-test probability. I mean, you still need a biopsy. So elastography tells you, here the necrosis is there, don't go there if it is malignancy. And with the blue part, the hard part you want to hit. So it just gives you a site where you want to go in. So elastography will just help in site selection slightly better than the B mode. But I mean, the game changer in this, I think it is the expertise. At the end of it, more procedures you do, the better you get at it. So I think after 40, 50, and your pathologist. So it's a synergy. It is your technique. So there is a learning curve for EBUS and there's a learning curve for the pathologist also. So both of you are learning together. So, it should be a good marriage between a, good pulmonologist and a good pathologist. That's the answer to it.
I think an MDT after the procedure.
Yeah, I think that we had a question on that. So
I would say
do you do that? I mean, anybody doing multidisciplinary discussion on this? For ILD?
Just before the procedure, yes, I'm doing it with my oncologist, but then.
Yeah. Yeah, but then that's a referral, isn't it? I mean, the oncologist refers to you, talk to him, and then you go ahead with the procedure. But then there is no and the pathologist gives you the answer or he refuses to give you the answer. So is there a true MDD in the true sense? I mean,
we do MDDs because we need to know what's our objective of an EBUS.
Exactly.
As I said, I have to know operability, non-operability, and know what I'm going for, whether I'm going for molecular testing or not. That's why we have an MDD.
Very valid point. Yeah. So I think that yes, for a person, I mean, Mahima, your team definitely yes, because you are dealing with cancer in a very big way.
But I think for the rest, we are pulmonologists kind of are our own MDD most of the time.
Let me name all the people without asking all the questions from them. But Hiten from Surat, thank you for your question. Robin, I'm going to ask that question to everybody. Role of Dexmed. I mean, are we using Dexmed as a standard of care? I use it occasionally, but what's your experience? All the faculty.
I use it more in thoracoscopies, but not in EBUS as such.
Yeah,
not much of experience of it in EBUS.
Anybody else?
We have used in few cases. So few cases we have used, but the issue is you always need to look at the heart rate, because a lot of these patients land up with bradycardia. Yeah. So it does improve, there is good sedation, which is there, the cuff count is less, but then you have to look at the, cardiovascular comorbidities. You have also got to look at the, hypotension and bradycardia. So it actually, what is important, whatever you're comfortable with, you should continue with that.
Yeah. Dr. Praveen from Hyderabad, we thank you for your question, and Dr. Bindu from Patiala, we also thank you for question, but I think both those questions are answered. Different types of needles, as well as most critical factors influencing the EBUS yield. So I think we have answered most of those questions. let me congratulate all the people who have sat through very boring people like me. I mean, and they have more than 2000 today. So 2012 was the last login. I think it has gone up. So possibly, I think that's a huge number of people which are attending this. And I think I'll go to all of you for one last closing remark. I'll start with who is the youngest? Vinod, are you the youngest? Start with you or whoever, who thinks is the youngest.
I
I don't
think I am
mind.
the youngest one.
I don't
I
mind
think I am the
volunteering for
youngest
that
one.
position, but Amina will
I
start with
think I
you.
Okay,
so
thank you. Thank you for assuming that I'm the youngest.
so you can go ahead, go ahead.
Yeah,
This
please.
is
So your closing remarks, please. How
Dr.
do
Vinod
you
something.
maximize the yield? Yes.
So can I go?
Yes,
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 please.
yes.
Okay. So the take-home message is for the learning curve, as Vikas mentioned in his slide. But the learning curve approximately around 2 years. Initially, you have to learn. But first thing, the practical way of learning is to make the how to process the sampling. The tissue is more important. You learn first how to process the sampling. Some months spent on the one table, that the processing of sampling. Then you became the ultrasound radiologist, like ultrasound. You have to just hold the EBUS scope and you do the ultrasound, identify the lymph node station rather than directly putting the needle. Few months spent while doing the ultrasound. If somebody is doing the sampling, you have to just to perform the ultrasound, identify the station, and then slowly you go on the passing the needle. Like there are multiple things. Initially, 10 years back when we learned, there was no stimulator with us. We directly learn, but now stimulator, multiple courses like the IIB is good. Taken an initiative to learn the theoretical aspect of the EBUS. So first, then before puncturing, starting to puncture the needle, go with the good theoretical, listen such video, listen and go through such videos and lecture. Tissue, then you have to learn the ultrasonography, find the station, and then the first important, go ahead with the first, if you are the learner, go with the subcarinal node. That is, you make sure that lymph node is more than 2 centimeters side, bigger lymph node. And if you want to really happy, go with the necrotic lymph node. That will give the answer immediately in 2 days. That will give us a good confidence to learn more things and slowly move on. There are the EBUS. What we are learn and what we are doing is the now EBUS, that there are more few advances we may learn in next series, like advanced EBUS, like cryobiopsy through the EBUS, like forceps biopsy. So there is and as Vikas sir mentioned, the learning curve, you have to perform at least 40 cases and observe at least under supervision. You have to supervise, you have to see the cases and then go ahead with the. So this is a training module. You have to just, you may not learn during the your PG, but you may learn during the your fellowship.
Amina, we'll come to you.
Yeah, so sir, I think to all the youngsters who are watching this webinar, what I'd like to say is that before becoming a good interventional pulmonologist, please try and become a good clinician, because like Dr. Mahima also pointed out, we need to know why we are doing an EBUS. Most of the times, you have people who come to you that, okay, there's a lymph node and now I'm going to do an EBUS. But if you don't know what you're looking for, if you don't know what you're suspecting, if you don't know what samples you have to send, the worst thing you can do to a patient is subject him or her to a long procedure and then come out
And
of
an
it without
expensive
giving
one.
an answer. Inadequate sample.
Yeah.
So first try and understand the case and then hold your scope.
Absolutely, absolutely. And in case of a doubt on FDG PET and another node which is completely biopsyable will avoid you much cheaper methodology, and that will give you the diagnosis. So very well said. Thank you for that. Mahima, if you are there, this is one question which is in case of an inconclusive biopsy. I mean, of course, your concluding remarks and inconclusive biopsy. This is come from. Somebody who's, yeah, the one last question from Kanaram, and he's from Ladang. So, in conclusive biopsy, what would you prefer? Repeating it, doing it with a bigger needle, or subjecting it to a surgical mediastinoscopy? I don't think anybody does it anymore, mostly not, but then.
Well, I think a mediastinoscopy would be an overkill. You'd first have to look into technical aspects of the first time it's been done and whether there was an adequacy on sampling. Was it a sampling error or not? That is what you look at. I would, if it's the mediastinal node and the best approach is still the EBUS, and so then I would still go ahead, but this time I definitely keep my Rose person sitting next to me.
Absolutely.
And if I've had a node, if there were multiple nodes and I did not have an FDG, a PET, then I'd probably want to do that and see which is the most avid node, if that can help me. And yes, if it was done with a smaller needle and there's still a suspicion, I would go for a bigger needle or go for more advanced techniques and using needle biopsies. If my difficulty in diagnosis is there, that's the only place I can. Only when I'm pushed to the wall, I'm going to send to a surgeon to do a MEAD. There are very few surgeons who can do MEADs, who are trained in doing MEADs today. Very few. Yeah.
Vaibhav, we come to you. I mean,
a definite closing remark. I think I'd like to add to Amina ma'am what she said. So yes, we are talking about EBUS. I think there was no word about conventional TBNS. So you should not forget choosing the apt patient, as I think Vikas sir also had rightly pointed out. The use of EBUS in the West was for staging of the disease. Whereas here in India, we are using it for tuberculosis, sarcoid, yes, all of the things. So the take-home message even to youngsters is, let us not forget the technique which was started way back in 1983, a lymph node size which is more than 2 centimeter, a station which can be sampled, and you think you can presume a diagnosis. So why subject him in a country like India? You see the dynamics, unless until we are using that needle thrice or 4 times or doing it in a wrong sense. So I think you can do a rapid onset evaluation with your conventional TBNA with a larger lymph node size. So an indication is very, very important, as Amina ma'am pointed out, that we should sit and discuss and see the size. In fact, one of my patients who recently came post TB, she had mediastinal lymph nodes and the lymph node size was around 2.5. I got a core even from the conventional TBNA. So you should not forget those basics. Start from there, see the indication, and eventually if you find, yes, this patient can be subjected, then go ahead with the EBUS. And then as going ahead, as Dr. Vinod has pointed out, this tissue sampling that ways, and also then you can go ahead with the forceps biopsies or cryobanks. So let us go step by step. Rather than jumping directly onto an EBUS, my take-home point to all the youngsters was, please do not forget your conventional TBNA, the lymph node size is above. And also, even if you're seeing a PET scan, you see there are certain nodes which are outside. You should not definitely always go in for an EBUS. You can always think of sampling the other sides, right? So it's not that we have the armamentarium and we have to use it or we have to prove a point. So you should realize each and every patient is different. Each and every patient's needs are different. And similarly and accordingly, we should go ahead and proceed that way.
Beautifully said. At the same
I'm
time,
going to say the question is for an undiagnosed mediastinal lymphadenopathy, right? That's why the question was, right?
Yeah, that's a different story altogether.
Yeah. So yeah.
We have
for that, we are
the
sending the patient to Mahima ma'am.
Yeah. You can.
No, these are two different subsets of questions.
Yeah.
Absolutely.
So from since you made me younger than him, I'm so happy we were going age-wise. I'm going to take full advantage of that. From the learning aspect, I'd just like to say that you have to be first a very good bronchoscopist, because many a times you have to switch. You have to be very good at your CT reading and know which node and which station and what vascular anatomy you're going to look at, and also abnormal variants of anatomies that you might see in your patient. And EBUS is actually some way an unlearning of bronchoscopy. In bronchoscopy, we stay in the center of the airway. We don't touch the walls.
Yeah.
And in EBUS, you actually start touching the walls. So it's sort of an unlearning. So the bronchoscopy should become like even in your sleep, you're able to do, it should be that good and, instinctive. And then you go on to do EBUS, you do it simulator, you do reading your preparatory. And I think there's Atul Gavande's book, which is checklists. Okay. Yeah. I think that's how you have to go with your patient, right? From start to end, checklist, go through everything, indication, what you're doing, stepwise, plan, have your team have everything, and then do it. And there is a learning curve once you do it. But if you follow your points and protocol, pretty good.
It's very rewarding learning curve. At the end of it, you deliver so much so into the patient.
Like we have 2 simulators in Tata for our residents. open all the time for them to come and practice, and even for observers, they come and learn on our sims and go. So
Absolutely. We
it's
have
pretty
one in
good.
Bhakti in Pune, so we have
Yeah.
some things where we can go and learn.
Yeah.
But first, the last question to you, and then your concluding remark. Mridal is asking, electrosurgical knife before an intranodal cryobiopsy, is that necessary, or the track made by the needle is good enough?
Actually, I think I was reviewing a Chinese study. So what they've
Yeah.
done is they said that if you're using a 19 gauge needle, you're adding to the cost. So if you're using, a 21, 22 gauge, the hole may not be good enough. So
Yeah.
these Chinese investigators, they used a electrocautery to just increase the size, so that your
Yeah.
cryoprobe can go in easily and the material also does not drop. So there is
Correct.
some evidence which is emerging, especially from China, where you use electrosurgical cautery and make a hole in the airway, and then you put your cryo through it, and then you get your tissue easily, back as well. Many times when you're pulling, the thing drops into the node itself. So there is some evidence to it. So, we'll have to wait and see. So it's a good question. I think it's work in progress.
Nice question. And your concluding remarks, there was one last question which was emerged, and I'll answer that and then I'll hand it over to you because again, what if litigation issues arise with ctDNA use when image guided FNA was available? If it is available, I wouldn't realistically do it without it. I mean, without a guidance, because that doesn't, if I don't want to charge the patient, I won't charge the patient. As simple as that. I mean, I'll do it ctDNA at a cost of, but I think I'll still use the guide. So I think one way or the other, if I have the technique available, I'll use it. If it is not possible to use it, and big nodes, 2.5, as Vaibhav very rightly said, then using a ctDNA is not a bad idea. And don't forget that technique of doing a ctDNA. That was his message. It is not that you don't use it and get into a litigation. That's not what we are looking for. If somebody is willing for a EBUS TBNA, I'm not going to refuse it. Why should I refuse it? Because guided is better. There's not a question on that. So because with that, your concluding remarks, and we'll find out.
I think most has been said. What I'd like to say is that, with EBUS, we have removed the largest foreign body from the airway, and that is a thoracic surgeon. Because there should not be any
No one's
need of
online.
doing a surgical mediastinoscopy any longer.
No, I don't think anybody's attending this. So
I think Dr. Amina, I hope you don't transfer it to Dr. Kamran, I suppose.
No, he's not in the room, so.
So having said that, we've already talked about the learning curve. So there has to be a structured program. Before you started using a EBUS scope inside the airway, you have to see a good number of ultrasonic images through the airway. Then you start doing the needling. I mean, that is the way we were taught. You have to know all the 14 steps, how to use the needle. So when we start, I was a needle assistant.
I'll interrupt you for a minute. The first time when we saw EBUS, very frankly, we did not know what we are looking at with the ultrasound. So I called my radiologist for the first 10 procedures to teach us what are we looking at.
Anatomy.
What is an hypoechoic lesion? What is the hyperechoic one? What is the central necrosis? So how does it look like? So I think it's worth getting that trained. Of course, we were early birds into this. So we were thrown into the deep sea directly. But for juniors, I think it's very important to what you are saying. So please continue.
So you have to have a bearings right first. You have to know the anatomy. You have to know how the nodes look like. What are the various stations? And thereafter, you have to become good at needling. And then you should be, putting in the EBUS scope. So this itself, so that's what I say, see one, do one, teach one. So, you have to see much more, before you start doing it. So you have to see at least 20, 30 to know the anatomy, how to maneuver. So you have to unlearn bronchoscopy. So what, my guide used to tell me is that, bronchoscopy is a wrist procedure. Whereas in EBUS, you don't move your wrist. The moment you move your wrist, the image goes somewhere else. So you have to keep your wrist absolutely rigid.
Absolutely.
It's like
in fact, it starts hurting. Very frankly, it starts hurting. It's as bad as that. You have to just keep it in, cranked up in a particular position for such a long time that the whole, your fingers start hurting. It's as bad as that, and that is correct.
And if you're not able to get the, image to the center, you move yourself. So this is something, again, what you don't do in a bronchoscopy. In bronchoscopy, you drive, you don't move. Whereas in EBUS, your hand is absolutely rigid and you move to get the image to the center of it. You learn a lot of needling, and then you should try doing it, and you should have a, very happy marriage with the pathologist. Otherwise, you'll not get any answer. So having a good pathologist is, as important as having a good technique. So these
I,
should be
I have been
the
proposing to my pathologist, but nobody has yielded, is it?
Sir, can I add one point?
Yes, please, Vinod. Sure. Your network seems to be a little wonky. We've lost you, Vinod. Is that right? Everybody else? I can't hear him.
Yeah, he's stuck.
Yeah, he's stuck. Okay, so I think with that, I'll conclude, and we'll pass on whatever that message he has to say to everybody on a DM message. No problem. So with that, I thank every one of you for being brilliant in contribution, commitment, and time spent. I won't say from the youngest to the A, but because you did a brilliant job of wonderfully delivering this talk. Vaibhav, you're absolutely spot on. Vinod, you are still stuck, but I think you will eventually come through. Amina, thank you for being with us. And Mahima,
Thank you so much.
thanks a lot. Thanks a million ton
Thank
for
you so
being
much.
with us and adding a lot from the Tata's treasure of experience. So with that, I conclude this session, and goodbye to all of you, and looking forward to you. Very happy Dashera. I hope the problem in Kolkata gets sorted out as fast as it can be, and we have a much better scenario there. And I hope Dashera changes that for us. Durga, the last Mahal is today. So I hope tomorrow things change as early as they can. And with that, I very sincere, heartfelt thank you for all of you for being with us, and all the delegates who have participated online. Thank you, and have a happy Dashera to all of you. Thank you.
Sir, thank you so much.
Dr. Nitin for a wonderful moderation as well. I mean, we need to
Yeah,
thank
wonderful.
you for taking it through so well.
Thank you, sir. Thank you so much.